Hello, everyone, and welcome. I am Sally Davies, Senior Editor at Aeon magazine, and it's my pleasure to host today's meetup under the auspices of the Brochure Foundation. So today our discussion will explore the notion of moral resilience, the capacity to respond positively and with integrity to a situation where one feels oneself to be ethically compromised or unable to act in accordance with what one feels is right. It's a concept that's of increasing significance in light of the COVID-19 pandemic and the pressures that placed on healthcare professionals, including doctors and nurses. Today, we explore the problem of moral suffering caused by some of the ethical conflicts that one experiences in hospitals and care settings, its consequences in terms of burnout and distress, and how the notion of moral resilience might help improve the well-being of and how healthcare systems function overall. So we're very privileged to have a panel of some of the leading practitioners and theorists in this area. Just to give you a brief sense of how this is going to work, we'll have a series of short 5-minute presentations from each of the panelists. We will do that in 2 tranches, coming to a total of 30 minutes approximately. And then the second 30 minutes, we're going to devote to discussions. So we do invite you to participate. Please drop your questions in the chat and we'll pick those up as best we can in the second half of the conversation. I do apologise in advance that we may not get to everybody's questions, but please do drop them in and we'll try our best to pick out common themes. So to start with, I'm just going to invite each of the panelists to introduce themselves and then we can kick off with presentations. Cynda, if you'd like to begin.
Hello, everyone. I'm Cynda Rushton. I'm the Bunting Professor of Clinical Ethics in Nursing. I'm a nurse at Johns Hopkins University in Baltimore, Maryland.
Thank you. Rachel.
Hi, everyone. I'm Rachel Chikondijia from Malawi. I'm a nurse by profession and I'm working with Lilongwe Institute of Orthopedics and Neurosurgery as a nursing director. Thank you.
Thank you, Rachel. And Ingrid.
Yeah, hi, everyone. My name is Ingrid Miljetag. I'm trained as a physician. I work as a professor in medical ethics at the University of Bergen in Norway, and I also lead the clinical ethics committee here in Bergen, at the main hospital.
Thank you so much. So to begin with, I think we're going to start with some introductory comments from Cynda concerning definitions, and then we'll go around and hear the short presentation. So Cynda, over to you.
Thank you so much, Sally. Just want to pause before we get started just to acknowledge what everyone has carried over these last 3 years and the incredible service that many clinicians have provided in the midst of really challenging circumstances. So I just want to acknowledge that as we get started. These have not been predictable times. They have pushed all of us to our limits. And I just want to acknowledge that as we get started. And thank you for all that you've done. So this is really interesting territory because the moral dimension of our work has often been conflated with other parts of how we show up and how we work. So I thought I'd start just with a few definitions. It seems that for the most part, what we are dealing with are different types of moral adversity. And moral adversity is an expected part of being a clinician. It's in some ways unavoidable. The question is how we respond to that moral adversity, that those situations where either external or internal circumstances produce some kind of morally objectionable, maybe it's even just a troublesome consequence that in some way imperils our integrity. And if you think about it, there are lots and lots of things that fall into that category. And we're going to talk about some of those. But in response to those situations, I would think that we could agree that there's a predictable sort of trajectory of responses. So the first one I want to just highlight briefly is moral stress. And I would say that that is that sense of arousal that we get when we recognize that an important ethical value is either threatened or violated. And at that point, we're in a state of, it taxes our integrity, our capacities, but doesn't leave us disabled. It's a state where we could actually resolve the situation. And it may or may not lead to what I'm going to talk about next is moral suffering. I use the terminology moral suffering as a way to encompass many types of moral suffering, the most common being moral distress, which is a concept that's been around now for more than 3 decades. It has many definitions, one of which is a situation where you recognize you have moral responsibility, you reason about what you think should be done, but either because of internal and external constraints, we really can't do what we think is right. That's the most studied form of moral suffering. But what we've begun to also explore is the concept of moral injury. And moral injury, I would propose, is a more corrosive form of moral suffering. It is where we experience a profound threat or violation of our moral foundation, our moral core and conscience. And it is often in response to really severe betrayals, either personal, leadership, or collective betrayals that erode our moral identity and our sense of worthiness as a person. And associated with this are more in extreme responses and consequences. I think in all of these cases, we can experience a kind of moral decline where our ability to perceive moral and ethical problems is diminished, where our actions are not in concert with our values. And always, when we are confronted with really hard choices, there is an inevitable moral residue, that sort of leftover feeling of ineffectiveness or shame or guilt that we've not done the right thing, even when, the choices, there were no good choices and they were inevitable in some way. So I just wanted to kind of paint the picture of the territory before we talk about some of the things that have produced this kind of moral suffering. So with that, I wanted to focus in, and again, this is a US perspective, but I think there's some themes that are pretty common around the world. One is that during COVID, the kinds of moral suffering that people experienced had to do with how we allocated our scarce resources. We didn't have, in many instances, enough medicines or PPE or people, most importantly. And related to that were a number of ethical responsibilities related to human resources. And I'm sure my colleagues are going to talk about this, the lack of people, not enough people to provide care for the huge number of people who needed care. And I think it left us feeling as if we had compromised the quality of care based on our pre-pandemic standards. And arguably in a pandemic, those standards can't be applied in the same way, but yet we held ourselves accountable for the same standards that were in place prior to the pandemic. And I think why this is different than burnout or just exhaustion is that it is a process that leads clinicians to feel that they have not fulfilled their ethical and moral responsibilities to their patients. They've witnessed people being harmed because they weren't able to provide that care, where they didn't have the resources to keep themselves safe. And in particular, in the pandemic, that was a different kind of calculation where people actually left their homes for long periods of time away from their families in order to provide care. And the increased risk to themselves, not having enough PPE to keep themselves safe. And one other topic that I'll highlight, and I know this is in particular very difficult for nurses, was the feeling that the care of people at the end of their lives was compromised. because of visitor limitations, where families were not able to be with their loved ones as they were dying. And in many ways, nurses, as the people who were at the closest and most sustained point of care, were really the surrogates for those patients as they were dying. Having so many cumulative deaths that at some level, I think we perceived perhaps could have been avoided, or in some cases were unavoidable no matter what we did. So I'll stop there and let my colleagues add to their experience around the kinds of moral suffering that have come up.
Thank you so much for that brief but moving presentation, Cynda. Ingrid or Rachel, do you have a view as to who you would like to talk next?
Well, we decided that I'll start and then Rachel will continue, of course. So thank you, Cynda. I think the kind of introduction to all these maybe sometimes overlapping concepts, or at least it's a lot of different definitions, so it's good to hear it from you. So my interest for moral distress and also moral resilience that we will come to, it came as I've done quite a few field works in sub-Saharan Africa, and also worked with clinicians there to try to develop various kinds of capacity building in medical ethics. And we tried to map out the ethical challenges or the ethical dilemmas that physicians were facing, first in Ethiopia and now later on in Malawi and Tanzania. But I felt that it's not only dilemmas that kind of trigger this feeling of distress, and especially, and Rachel will come into this, that we're in a setting where it's very limited resources, but you still know what is medical right, but also ethical, kind of what you want to do, but you cannot do that. And then I started reading about this concept, and I saw also in the work I do here in Norway and stuff I made here, also examples of moral distress. And we started to do several studies on that. And just to give a short glimpse into one unpublished study of moral distress among physicians in Norway, what they report is a very high level of moral distress related to time constraints. So compared to the maybe Ethiopian or also the Malawian setting, we are fortunate in Norway with quite a lot of resources, but time is limited. And I think that was also something that we could see during the pandemic, that you didn't feel you have the sufficient time for proper care. But it's not like the care for patients is really hard compromised, because what we see is that the healthcare providers really stretch themselves. So it rather affects them than the patient, because they're very reluctant that it will have bad influences on the patient, that they don't have time. And also some of the time constraints is related to so much of their working day is related to or used on administration and documentation. So what we see is that even if we are almost double as many doctors in Norway now than 20 years back, they feel more time constrained, because it's a higher demand, I think, more old patients, and that will really increase. Also chronically sick patients that now can live but really need complex care, and also a lot of new very advanced treatment options. So this issue with the time constraints is really there. And just one other example from the non-Norwegian setting is that, and I think you can find that in both places actually, that there's limited time to meet your colleagues. That maybe we will come into that, what can really support you in these situations, but that time also disappears. And just one introduction also to Rachel, that our participants in the study in Ethiopia, they talked about how they get stressed because so many of the decisions are pushed down in the clinic with fewer policies that or priority setting guidelines, or also maybe clinical guidelines adjusted to that setting. So a lot of decisions they have to do themselves, as well as also trying to protect patients from out-of-pocket expenses, really poor patients, and you give a medical advice and you kind of feel this stewardship responsibility for the family welfare as well as the individual health benefits. So, but you know, Rachel is the right one to talk about these things. So over to you, Rachel.
Thank you, Ingrid. Rachel, would you like to jump in here?
Thank you so much, Ingrid, and thanks for that introduction. Similarly with what just Cindy mentioned, indeed, from my perspective, like mentioned, the common cause of moral distress is shortage of resources. And this is both human and material. And so you're working in a facility or in a place where you're a few of you, sometimes you are even alone. At the same time, you also do not have the resources that should help you do the work. And so you are constrained. And it really becomes a burden where I'll just be bringing up the real examples where you're in a setup where you should make sure that this patient is getting this thing without using their money. But at the same time, if you don't tell them the truth that they will not get this if they don't use their own money, so you're in a fix. You have to be open to them and tell them to say, oh, but we do not have this antibiotic, we do not have this, possibly you need to buy. But at the same time, you also need to, you're looking at this person, this is not someone who manage. They don't have anything they can bring out from their own pocket. So it's a challenge. Just going back a bit, I would say I find that moral distress is something that has not been discussed much in our setup. I just liked what Ingrid mentioned. I'm a very good example of itself, because I remember there was a time when I went straight to my boss and told her to say, you know what, I think I reason very well, but now I can't think, I can't be productive anymore. And you know what, I could not even know that I had a burnout until when I was taking a course away from my actual nursing thing. I just felt, you know, I was just searching for something different that would give me peace, something different that would make me feel comfortable. And so I ended up going in this course that was something to do with community-based work for children and the youth. I felt like maybe I will find peace in doing that thing. But that's when I learned from that course to say, these are signs when someone has a burnout. I went back to work and I told them to say, you know what, guys, I have a burnout. I need to go for a break. I liked it last time when Ingrid visited Malawi and we are in a meeting, she was making a presentation, and you'll find that even most of the managers do not understand this, and so this is the challenge. It is not being addressed either. Because we feel if we are to be productive, we need to keep these people around instead of addressing the situation. What is it that is making this nurse say, I feel like I should just drop my work? I feel like I should just maybe do something different. What is it exactly that is bringing out these statements from the nurses? You know, you go down it, then they'll start telling you, you know what? I'm working, this child needs oxygen, but I can't just even access the oxygen tubes, that I need to help this child to be on oxygen. How does that feel? And you're running up and about in the facility, and then the guardians are following you and they're telling you, no, come back, that child is dead. Instead of you being the one to console them and say, I'm sorry, we did what we could, but the child is gone. So it becomes now traumatizing. It becomes so disturbing. But as we continue, people find ways of coping. They still find ways of, you know, adapting. So I find this also to be in both sides, both positive and negative. you find that when we're talking of moral resilience, at least you should not remain with some damage. But in our setup, you'll find that now we resort to possibly maybe improvising. Now you're not addressing the real problem, but you're just still addressing what is it? Okay, it's because of resources. What do I do? Okay, I needed to have a straw for my patient who has done intramandibular fixation. They need a straw. What do I do? And then you go and cut a nasogastric tubing, and then you give them as a straw. Just an example. But tomorrow, you will now have a patient who has a distended abdomen. They'll need this tube. Now, tomorrow, you don't have this nasogastric tube that you had cut yesterday. So it's just that cycle that you're not solving the problem. You're just going in circles on the same, in the same thing. But at the same time, on the other hand, I saw it with the team I worked with when I was working in the main hospital. You build the muscle. You find that now you're telling yourself that this is the situation we're in. We cannot be weak. We are only few nurses. We have 91 patients in this ward. At least we should have been 8, 7, something like that. But we are only few, 11 covering this whole ward. What do? You find yourself alone, or a maximum of 3 or 2 in a shift. And so you learn now to work faster and to prioritize things and to make sure, and now to start clustering your patients. Those that need close attention, we need to put them in a same room so we can address them, we can look at them. And now you start making ways that you can cope and address this situation. It's one of the things that I've seen it happening and working with us, understanding our situation, our environment, and seeing how best we can work out in it. And then sometimes when we come and the word is calm, we're like, oh, there isn't much to do today. What's happening? Because now you've gotten used and then you've managed to find ways on how you can work out around the same situation. So that's how we're coping. But there is really still more to be done as far as moral resilience is concerned on the other side. I think I can stop there for now. Thank you so much.
Thank you, Rachel. That's really fascinating. And I think a perfect on-ramp now for the second half of the presentations, which concerns moral resilience as a coping strategy for moral suffering, distress, stress, and trauma. So Cynda, back to you to open out this somewhat more positive and forward-looking aspect of the discussion.
Yeah, thank you so much, Sally. And I think it's very clear that we're all in the cauldron, if you will, of moral suffering and unresolved ethical challenges. I want to say a little bit about the concept of moral resilience and to clarify a few things about it, because sometimes people are prone to reduce it to a soundbite, and it's actually much more complex than bouncing back, which is what has some people have referred to it as. I'm not sure it's really a coping strategy either. I think it is building our internal capacities to address moral adversity, and some of that is unavoidable and some of it actually is modifiable. So always in our work, we have talked about both moral resilience at the individual, arguably at the team, and more collectively, but it is always understood in a culture of ethical practice. So it's integrity as the core, moral resilience is what can support that integrity in the context of a culture of ethical practice. So all three parts are needed in order to create a wholesome environment. So moral resilience really came out of spending decades focusing on the problem side of this. And I kept asking myself, and so what else is possible? Are we just going to be stuck in the distress and that's it? So I was actually at Roche, and I was there for an intensive period of time, and I began exploring this question. So it came out of trying to locate what the moral dimensions of resilience might be. the human experience, the moral complexity, the ways in which we do find ourselves in situations that compromise our wholeness, our sense of integrity. The resilience side, actually, much of the research is focused on our response to adversity. And this is part of that application. It goes way beyond bouncing back to actually being able to meet those challenges in ways that don't disable us and potentially might lead to growth and transformation. And the other assumption is that our resilience, our integrity is an inherent state that can either be amplified or degraded, but it can't be extinguished. And so I want to just put a fine point there, that we are not starting with a deficit model here. We are starting from a place of acknowledging our wholeness and our humanity to start with. So we have developed, we did research to identify 6 elements that are related to moral resilience that is grounded primarily in personal and relational integrity, buoyancy, self-regulation and self-awareness, moral efficacy, and really importantly, self-stewardship. We've developed a tool to measure moral resilience, and we've done research that indicates that higher levels of moral resilience are associated with lower levels of moral injury symptoms, moral distress, and mental health outcomes like stress, anxiety, and depression. Also, higher levels of moral resilience are associated with lower levels of burnout and turnover in tension. And what we've come to realize is moral resilience actually is a protective resource that is not meant to turn us away from the hard things or to make us numb or complacent or to put the blame on us as individuals, but to allow us to meet those challenges in the most healthy, wholesome way possible. I would say in many ways, what our research has reinforced. In one study, what we found when we looked at organizational effectiveness, moral injury, and moral resilience, that for every 1 unit increase in organizational effectiveness, moral injury symptoms decreased by 0.4 points. For every 1 unit increase in moral resilience, moral injury symptoms decreased by 1.14 points. And so our conclusion is that we need both. We need to restore our sense of agency as individuals in the system to support our wholeness and well-being, but we also have to engage in system change. As Rachel was pointing out, it's not either or, it's both and. So I'm going to turn it over to Ingrid.
Yeah, thank you very much, Cynda. And I think we have so much to learn here. And I found that when I meet staff and also meet students and talk about moral resilience or moral distress, they can identify with this, or they have their own examples of this. And then the question comes, so what can we do? What can we do to reduce it, both at the individual level, but also what can we do within the team? The managers ask, what can we do about this? And also, of course, as a society. And then I think to have this more positive entrance into what we can do ourselves, but also those of us who work with more ethics support and staff support, then this is, I think, a very fruitful way of thinking. Learn from those who seem to be very resilient, because you see different staff handling things very differently without being, as you say, detached or anything, but really, what do they do? What kind of strategies are they using? And also, I think especially managers are extremely important. We did some studies during COVID here among staff and asked them what kind of support is important for you when you're in kind of the stressful or the ethically challenging situations. And what comes up is, not surprisingly, to talk with their closest colleagues. So I think the team and how we talk together, how we support each other among our colleagues. But what was also important was how their closest managers handled the situation, and as well if they had guidance on what to do in the most challenging situation. So I don't know if this kind of is a response, but I think trying to look for what works and what can support and how we can thrive and grow is a very interesting way into the field of ethics, I think. So, so let me hear what you say, Rachel.
Yes, I agree. In the course of before I became a nurse leader for the entire nursing team, I realized that there were just those moments when I needed my supervisor just to understand and just to support me, you know, where they do not come and ask me to say, oh, how is your unit? And I tell them, oh, it's very busy, I'm alone. And then they tell me, let me know when you need help. To me, I said, no, I needed them to jump in and say, you are alone, I'm already in, let's work together. Though I was alone, just to see another person, even if they'll do little things, but to you already, it means a lot. And so the small things, the small other things they can help with, the other things they can touch on, already they make you feel, okay, at least we are a team. And so you feel energized. And when you were feeling like already I'm tired before you start working, you start feeling that, yeah, at least there is someone who minds you can talk to. So indeed, I agree. I've learned in the course that working as a team is also another very important thing. And not just saying that you're doing things together, but where you have people that you can rely on and you can talk to, even when you do not know how best to handle the situation. You know, when you are a team and you are able to share and discuss, and someone says, maybe we do it this way. Maybe it's because we are lacking guidelines on this. We need to sit one day and just make guidelines for this. Already it starts solving the other problems. And then as a team, you're already also finding solutions. As Cynda mentioned, it's not like the other things we can get rid of them. They will be with us. But how do we work safely with them that we are not being damaged and that our patients are safe? And so this is where, when you're working even as a team, you're also finding solutions to say, oh, maybe it's because we don't have guidelines. Oh, maybe if we just have a policy on this, we will not have challenges in making a decision to say this is how we're going to run it. And so to me, this has also proven to be one of the things. We can't really say this is one solution, but we've seen them working. We've seen them yielding results and helping out. But at the same time, small things, like in my setup, motivating the people as leaders. We can't talk, when you talk about shortage the other time in other European countries, they told me the same. Racial shortages everywhere. Cynda is in the US, she'll tell us shortages everywhere. And so this is a problem that we're not gonna just get rid of it in today, but how do you make these people that are working so hard and tireless to be encouraged to do more? You know, so small achievements. Now the fact that I was there down and then you've gotten there, I tell myself I should be a role model. I should be one of those leaders that I wanted to have. I felt I needed someone who encouraged, I needed someone to motivate me. I needed someone who just step in the word and say, what should we do to make things better in this situation? And so to me, it's all that. The leadership issue that we step in and work with the nurse and be together in it. They're not alone. They're not just alone on that bedside and failing to make decisions. Sometimes we've also overwhelmed them. Oh, we need to make standards, and we are also pushing it down to them. But we can say, all right, how do we want it to come up? And we start drafting something together, and then we show them. Then we've already relieved them of other duties, and then they are concentrating on a few things. I've just focused on the practical side because that's where I've stayed longer, and this is where I've felt things have worked to help as far as moral resilience is concerned. Thank you so much.
Thank you all. I think that gives us a lot of rich material to start the discussion. I think, I mean, there's two themes that have come out very strongly for me from these presentations. And one, of course, is the sense of culture and the collective and the need to be seen, the need to be heard as a huge part of the solution. And I think the second is this question of the individual versus systemic interventions to improve moral resilience. Now, one thing that jumps out at me about the notion of integrity is that it's an intrinsically personal quality, and that what one person considers integrity to be is necessarily going to be different to another. So I'm curious to hear from the panel about how we square that necessarily individualistic conception of moral integrity with the necessity for healthcare systems to operate according to protocols and standards, and indeed that sense of having standards, that sense of having guidelines, that sense of there's a playbook for us in these situations is a big part of what can foster people's moral resilience. So I just wonder if anyone from the panel would like to pick up that question of balancing the individualistic aspects, or maybe not individualistic, but the necessarily personal aspects of integrity with the need for systemic approaches to standardizing responses in certain ethically challenging situations.
So I would like to take that one on. Two things. Moral resilience includes relational integrity. And I think what we're really talking about here is, in order for us to have relational integrity, we have to know who we are and what we bring and how we show up in these circumstances. When we talk about team, it is about how our collective integrity aligns with each other's. And I do believe as human beings, we resonate with each other's attitudes and each other's integrity. When we're acting with a group that has high integrity, the likelihood is we will too. And so I think there is this collective experience of how we show up together as whole people, how we create an environment where we actually have an inclusive space where no one is diminished, where we're all whole, and no one's really left out of that conversation. And that's where being heard, being able to actually have an environment of inclusiveness, where, as Rachel was talking about, you know, it is our teams where we find support, where we find this collective strength. And I think that that is a dimension that has to be taken account of. The framing of individual versus the system is problematic, I think, for a number of reasons. One is that by saying it's all the system, it basically abandons the individual. You know, system change, we didn't get here overnight, and we're not going to change this overnight. So the question is what do we do in the meantime? And how do we support the collective well-being and integrity of everyone in the system? Because whether by choice or by circumstance, we are the system. So it's trying to think about how do we do both in a kind of social ecological framework. You know, a change in one is going to institute changes in the other. So as we change as individuals, our teams will change, our communities, and the broader context. And I think a lot of our work has been about restoring our sense of agency, because what you hear most commonly around different types of moral suffering is the sense of powerlessness. And so if we can restore our capacity to see ourselves as whole, see ourselves as capable of responding to these challenges, of being able to have a repertoire of responses that include compromise, raising our voice, refusing, and potentially even exiting from toxic situations that are not healthy and wholesome and are not changing in a way that allow us to be in integrity. I think that we have to really invest at both levels. Ingrid and Rachel, what do you think about? What do you want to add to that?
So yeah, it's a lot of things, and I think we should also see if we have more questions from the audience. But I think this what you say, Cynda, that we can't only wait for this. We should try to improve the system and raise our voices and act, but we have to survive and thrive along the way. And I constantly get questions from clinicians. So can you give us some tools? So that's what kind of tools can you give in this field? I like to ask that back to both of you, but I think something is that just to get the awareness, as you said, Rachel, that just trying to talk with people, this is actually what you feel. It might be moral distress, what you're telling me, and this is very common, and what is it in a way? And also what I believe is that clinicians also need to work on skills, on things that they find difficult, and that we actually maybe during medical school or nursing school do not provide enough training in communication, for instance, training in how to handle conflicts, saying no, dealing with these difficult things. That skills in these things can also be, you can practice and be more prepared. It doesn't get easier necessarily, the problem doesn't disappear, but you maybe feel a little bit more prepared, and that can kind of calm you down a little bit. And of course also more understanding and knowledge of variety and so on. But let me hear from you again. Would you say something, Rachel, or?
Yeah, so it's true. I agree with how even Cindy approached it, to say usually we wouldn't say that this one is very important and then we leave out the other one. As an individual, it is also very important for me to know myself, know what I'm capable of handling, and also, as we're putting it, I need to understand what is this that I'm going through, and I should also be open enough and discuss it with other people, because then you're able to get the help. At the same time, you can also be able now to bring in the aspect of the team, and then you work together and say, all right, this can be worked out in this way. And so even from the beginning, the way I looked at it, like the way Cindy brought it, we just have to balance both. You need the other side. You also need the people to know themselves, to work from there within. Because we have, in my setup, we have some situations where you are alone. You are alone with 90 patients. Here, you are the team. So you can talk of other people and whatever. But here now, the systems are what will help you now to say, all right, what do I need? Maybe on this, there is a procedure, or there is a policy, what we follow. And so now the system will help you in this situation. And so you find that there is really need to strike a balance. You need them all. And I find them all to be very important. And indeed, we need people to also work as, like we talk about, interdisciplinary meetings or working together. The clinicians, the nurses, even people in the other disciplines to come together and work together, not just the nurses team, but even the other disciplines. I find that it also helps a lot, because sometimes there is also this tendency that we sometimes have to push it on one side. Oh, this is for nursing. This is for the clinical side. This is this side. But when you come together, it also protects the other people in the other side. And so you agree on, for example, standards that will now help both areas. It's not just for the nursing, but all right, even in the clinical side, it will protect them. Even the team, the paramedics, it will protect them and it will help them to make a proper decision. And so that way we are all safe. And most importantly, our patient is safe and has been assisted effectively and efficiently. Thank you so much.
Thank you very much. I just wanted to apologise, by the way. I understand that the chat has disabled, but I can now see that there are questions coming through in the Q&A. So I am going to pick this up. A very interesting question coming through from Faith is some of these strategies that individuals can employ to develop and strengthen moral resilience in the face of challenging ethical dilemmas and moral distress. And perhaps I'll combine that with another question that's come through from Sharon Petal, which is is there any interest in this question of moral damage and resilience in other professions? And I suppose it would be interesting both to see whether or not the literature and science of moral resilience that's been developed within healthcare settings can be applied elsewhere, and likewise whether analogous research that perhaps doesn't fall under the label of moral resilience but actually has a lot of crossover from other disciplines or other domains has been brought into the literature of moral resilience. Cynda, perhaps you'd like to jump in there.
I'd love to talk about that. I think the whole world is experiencing moral suffering, quite honestly. Everybody. There's nobody who's not experiencing some kind of often a lot of suffering about some of the hard choices that have been made in the world we're living in, violence. You could just go on and on. So I think that's absolutely true. We have seen a lot of research in other disciplines besides nursing and medicine about moral distress and now moral injury. What I wanted to share about strategies, since 2016, we have been implementing a program called the Mindful Ethical Practice and Resilience Academy for nurses. And we did pre-post 3 and 6 month follow-up on the impact of that intervention that really focused on first creating a foundation of stability. So mental and emotional stability using skills like mindfulness to recognize when we are out of balance and how we can get ourselves back into a more stable place where we can perceive things clearly and respond rather than react. Then the issues around how do we cultivate, and I know Ingrid is very involved in this, is developing the skills around moral competence to recognize and respond to ethical challenges. And it does require a new vocabulary, a way of thinking that many clinicians and others don't have. And so that's a gap that we can address collectively. Practicing, how do we speak up with integrity? How do we actually bring these issues into our clinical work in a way that can be heard and understood? And then the third part of that was around developing self-stewardship, which is seeing ourselves as worthy of our investment in our efforts to be whole. And I'll say, I don't think the system is ever going to care about our individual well-being as much as we do. So I think as an individual person, we have to see ourselves as worthy of that investment and to take steps to, first of all, know what nourishes us, but also what depletes us, and how we can be responsible, mindful stewards of our own resources, which means sometimes we need to say no. Beyond this point, it will cause harm to myself and others. So we implemented this program. We saw statistical improvements in work engagement, in mindfulness, in resilience, in decreases in turnover intention, depression, and anxiety that were sustained beyond the study period. So there's something that when we get a collective of people who have those skills and talents, what we began to see is on a unit where there were a number of people who had been through this program, they were able to actually support each other to do the right thing more often and to problem solve through what are our resources, how do we activate them, how do we be a collective voice to bring these issues forward in our organization and beyond. If you feel disabled, you are not going to have the energy to engage in problem solving or system change. And we need everyone to feel capable to do that, to make the kind of change that we need.
I think a really interesting question that's coming up here is about agency. I mean, I was even thinking, Rachel, of your example of cutting the straws in response to this immediate need. I mean, this is not necessarily a strategy for cultivating genuine moral resilience, but a coping strategy to enhance a clinician's sense of agency, of sort of, I'm able to do something in the face of what could otherwise be a disabling moral challenge. I'm conscious that we've just got 10 minutes more. So what I'm going to do is I'd like to bundle together a couple of questions and then pose a question of my own. We've got some questions coming through from Rosemary Field and Murad Khan about ethical leadership and the concrete ways in which that can be embedded in organisations and how organisations can move to moral resilience. I'm conscious, Cynda, that you spoke to that to some extent in our last question. I'd also like to pose a question concerning this 6-element structure that you set out, Cynda, about moral resilience. And I'd just like to question the extent to which that is culturally transferable across all healthcare settings. Is it the case that those 6 elements are applicable regardless of the cultural or national context in which the care is being provided. How has that been tested? And if not, I'd be curious to know kind of, are there different culturally specific aspects of moral resilience that might obtain in other settings? So first question about embedding ethical leadership within systems, and then the second question about the universality or cultural applicability across cultures of moral resilience. Would anyone like to jump in there?
Go, Ingrid.
So I have one input to that, and it's also maybe linked to one of the other questions here, that if you kind of dig into who experience moral distress the most, there is quite a lot of research on that. And we see that those who are young and unexperienced, and women, and those who were placed in a different ward during the pandemic, for instance, also maybe nurses experience it more. And we've looked into various specialities. For instance, we found a much higher level of moral distress among staff working within psychiatry and addiction medicine. So I think it says something, even if it's not across countries, it at least says something that it depends who you ask and what kind of context they work in. And that says something about maybe, of course, persons working there, but also the environment they work in. So Cynda and I have been fortunate to have not a webinar on Roshare, but a seminar, a 3-day seminar next year, where we really would like to try to explore together with colleagues from around the world, what does moral resilience look like in their setting, and is it something that we can say is global, so to say, or is it very is that not possible? Is the contexts that Rachel and Cynda and I work in so different that this will play out very differently? So next year, maybe we can answer you a little bit better, but we'll see.
Interesting. Rachel, did you want to speak to any of these questions, either about practices for embedding ethical leadership, or else the cultural applicability of moral resilience in different settings?
The example I gave first mentioned that I find that in some setups, people do not even understand that this is moral resilience. So you would find that it's not there, but now just to realize that what I'm experiencing here is moral resilience. And so I would say, if this is studied more even in these setups, now this is what will open people's eyes, and now to start understanding, to say, oh, all right. Like I gave my own example. It took me to understand that what I'm experiencing is a burnout. Not for me to start searching for other things to do is going to solve this, but taking a break is going to solve this. And then I came back fresh. So I would say, Cynda mentioned this, to say everyone is experiencing this. And so I guess possibly in other setups, it has not just done research and to realize, or some people have not just come to realize this is moral distress. And then you can start tackling something you don't understand. And so until people get to realize, oh, this is it, then we will give it a proper approach. I would comment in that way. Thank you so much.
Rachel, I think your point's a really good one. You know, sometimes we don't know what to call what we are experiencing. And I know that many times when people have the vocabulary, they're like, oh, a relief. I'm not deficient. I'm not a bad person. I am experiencing a predictable response to a really difficult situation. And it's not because I'm weak. It's not because I'm not smart enough. It's not because I haven't tried hard enough. You know, you can accept that this is the situation we're in without agreeing with it. Accepting it doesn't mean I agree with what we are doing. But there's something about shifting from that feeling of ineffectiveness to saying, this is what we are in right now. What can I do with the resources, the time, the expertise I have with the situation that I'm in? And then to be willing to turn toward those limits with some compassion rather than judgment is, to me, a huge step forward to give us all a little out breath that we're not failing because there's something wrong with us. We are not. And the other part is leaders are struggling too. I mean, you hear Rachel talk about the hard choices she has to make. Leaders are making hard choices too. And yes, we need leaders who have the ethical capabilities to name these as ethical issues, to apply these tools and strategies to address those issues. And that, in addition to then seeing ourselves as part of communities that are interconnected with each other. We're not just islands. We are all connected with our patients, with the people we're serving, with our colleagues, with our leaders, and on and on. And so I think part of it is we have to be realistic about what actually is possible, what part can we modify, and what part will never change. And try to put our energy into the parts that are modifiable, because we're just going to exhaust ourselves more by railing against things that cannot change.
I think that's, oh, sorry, go on, Ingrid.
No, I was just also adding there, because I think when we kind of look for solutions for how can we work on this, and maybe then also ask the clinicians, what will be useful for you? And then I find it, I'm quite optimistic, because what they ask is to have time with my peers. So I can check out before I leave home, that I don't bring with me all this distress, but I kind of leave it here. We kind of see each other. So for us in our study, we saw that kind of the more external support, like psychologists or clinical ethics committees, or any of this kind of, that leadership during the pandemic was very eager to understand, will this be useful? It was very long down the list, because it's a high threshold as well. And what you actually need is someone that knows the situation, your leaders, your colleagues, also maybe your family. They will not, of course, know all the details, but actually that's some days you come home and you just need to have a little time by yourself, or you need to go work out, even if the house is very in need of getting cleaned up because of what you have experienced at your job. So I'm quite optimistic that it is doable, but it's also, of course, nothing we can solve. It will always be there. I think it's continuous, something that and it's part of moral distress, is also part of being a caring person. And it's not wrong always to have these kind of moral challenges when you meet people as you do as a healthcare worker. So
I think it comes back to something Rachel said, which is, the response to these situations of inadequate resources and moral challenges that arise to say, well, we need to keep people in the situation, we need more bodies on the ground. But I think one of the very strong things to emerge from this discussion is that some of these more oblique solutions that seem like they are potentially exacerbating the problem in the short term by allowing people to step away for a period of time to gather their resources, to talk to others, these are actually crucial aspects of cultivating moral resilience. So accepting that obliquity and creating spaces for safety and vulnerability among people who have to wear a huge amount of responsibility and authority in their day-to-day lives. So thank you all for an absolutely fascinating and very important conversation. I'm sorry that we didn't get to everybody's questions. I'm sure the panelists would be happy to follow up afterwards. But thank you all very much for your attention and sharing your thoughts and expertise. And thanks also to the Brochure Foundation for facilitating this discussion. We'll appreciate it hugely. Thank you all. Bye-bye.